Good evening all, welcome everyone to the PG case presentation series conducted by IRIA Kerala on the platform of Janomed. And towards this, I welcome Dr. Gomati Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shenai, Program Coordinator. And today the topic is in head and neck, imaging in head and neck. And this is going to be presented by 3 postgraduate students. And the coordinator is, one minute. Coordinator is Dr. Sunimol, consultant radiologist and academic coordinator, Kerala Institute of Medical Science, Trivandrum. And our faculty is Dr. Rashmi CP, is consultant radiologist in Anandaburi Hospital and GG Hospital, Trivandrum. Hearty welcome, Dr. Sunimol and Dr. Rashmi. And now over to Dr. Sunimol.
Yeah, before going to Sunimol, I just want to tell that we are running this academic session from January onwards, and today is our 60th academic session. And we are very happy that we have completed 59 and today is 60th. And the credit goes to our Kerala IRI team and academic chairman and all the zonal coordinators who have helped us to run this session. So I take this opportunity on behalf of Kerala IRIA to thank each and every one who is in our academic team. And we have the 28th quiz also running, which is running very successful. Thank you so much. Over to you, Suni.
Thank you. Good evening all. Very happy to host the 60th case discussion in this series of IRIA academic program. And I thank Gomdi ma'am for the spirit, the team spirit which she is encouraging us all. Venu sir, Ramesh sir, IRA Secretary Rijo Matthew sir. So we are happy to host the presentation at Trivandrum, PGs from KIMS Trivandrum, and both of the zonal coordinators are here, Rashmi and myself. Rashmi is the faculty today, guiding the presentation on head and neck series. I welcome Dr. Rashmi. She is the consultant in Anandaburi Hospitals and GG Hospital and active participant in the academic programs, the case discussions, the quiz, the FRCR teaching program. And I am very happy to welcome her to this, especially to guide my PGs of KIMS Hospital. And the PGs, I will have a short introduction. Dr. Rosmi, Dr. Maria, and Dr. Vijay. They are primary DNB final year PGs. The next exam going batch, coming exam going. So over to you, Rashmi, and welcome.
Thank you, ma'am. So thank you, Venu sir, Gomati ma'am, and Sunimol ma'am. So we'll directly go to the cases. So I'll be showing the cases. I'll be showing directly from the DICOM viewer. So the first case, I think Rosmi will be seeing, right?
Yes,
ready? Okay.
Yes, ma'am.
You're seeing the case?
Yes, ma'am.
Okay. So this is a 60-year-old female patient who presented with a nasal obstruction and epistaxis. Okay, so you have the plain soft tissue window here. I will also show the bone window. If you want the coronal view, you can always ask for that. So you can start describing. If you want any specific region to be focused, you can tell me, or you can just describing what you're seeing. Okay, so this is a 60-year-old female presenting with nasal obstruction and epistaxis.
Okay. So
This is the bone window. If you want to see the soft tissue window, I will move to the soft tissue window, and there is contrast also. And when you want the contrast, you can ask for that. Okay.
Okay.
Yeah.
Can I have the soft tissue in the middle?
Yes.
Okay. So there's a large soft tissue attenuating lesion that is seen involving the entire left nasal cavity and also left maxillary sinus. We can see that the mass is seen displacing the nasal septum towards the right side. And bone window. Mass is also seen involving the ethmoid and frontal sinuses. And we can see that there is a irregular hyperdensity that is seen within the lesion, which is similar to the density of bone. And
Yes.
the medial wall of the maxillary sinus, part of the medial wall is not well visualized. And there is thickening and sclerosis of the lateral walls of the maxillary sinus. And this lesion is seen extending superiorly to the cribriform plate and the roof of ethmoid sinus.
Yes.
Post contrast can you see?
So this is the plane, and this is the post contrast.
Post contrast images show heterogeneous enhancement of the lesion. We can see there are few linear or few irregular hyperdensities also within non-enhancing areas. There is no evidence of any bone destruction maxillary except for the medial wall. Other bones appear displaced and expanded, but no evidence of any aggressive destruction. And so
Yes.
and there is the lesion is also extending. There is no evidence of infiltration into the sphenopalatine foramen or pterygopalatine fossa.
Okay.
No definite evidence of any intraorbital or intracranial extension.
We can conclude, and you can come to the differential diagnosis. Then we'll discuss the case.
Okay. So to conclude, a 60-year-old female patient with a large soft tissue attenuating lesion that is seen involving the nasal cavity and also maxillary sinus and ethmoid sinus, and with a bone density within the lesion, and with no evidence of any extensive bony destruction or invasion into other adjacent structures. Considering the age, sinonasal carcinoma can be a possibility.
You said that there is no bone destruction, right?
Yes, ma'am. That is one fact that is against sinonasal carcinoma.
Any other DD?
Another possibility is inverted papilloma, ma'am, which can show this. There will not be any evidence of bone destruction, and they arise from the nasal cavity, lateral wall of nasal cavity, and they can also extend to the sinuses, and they can show this hyperostosis within this inverted papillomas can show hyperostosis. So the bone density within can be hyperostosis of the inverted papilloma.
Okay, very good. So what do you think from your description, what comes first, inverted papilloma or sinonasal carcinoma?
Inverted papilloma, because sinonasal carcinoma, there it will be more aggressive, there will be more bony infection and invasion into adjacent structures.
Yeah, so see, the way we have described this is like a slow growing tumor. You specifically said there is no bone destruction. You said it is expanding the nasal cavity. You said there is a focal hyperostosis. And then suddenly, when you summarized it, you said the possibility of sinonasal carcinoma first. That should not be like that. See, if you're telling that, if you're describing that like a slow growing tumor, you can always you can tell the possibility of sinonasal carcinoma, but a second DD. But the way you are describing, see, it's always like that. In the exam also, if you're describing something like this, you should point towards a diagnosis. So if you have inverted papilloma in your mind, you have to describe like that. You have sinonasal carcinoma in your mind, you should describe like that. So that is the basic point in any examination. So examiners always want you to be describe a lesion in the correct manner and come to a diagnosis. Okay, so what is the actually role of imaging in a paranasal sinus tumor? So this is a mass lesion or a tumor-like lesion in the paranasal sinus. So what is the role of imaging, and as a radiologist, what are the things that we should check?
CT will help to identify the bony changes.
Not CT. What is the role of imaging? Actually, in most of the cases, it is very difficult to tell the histopathological diagnosis of sinonasal tumor. But there are certain things that is expected from a radiologist. So I'm asking, what are the points that you should always describe or come to the in your report? What are the points that you should always mention? And rather, what is the role of imaging basically in a sinonasal tumor? So see, what is the most common sinonasal lesion that we come across in our routine practice?
Sinonasal polyp.
Yeah, it is basically sinusitis, and it's the different types of sinusitis, polyposis, like that. So basically, first we have to differentiate that from an inflammatory disease. So how do you differentiate a sinonasal tumor from an inflammatory mucosal disease of sinus?
MRI will help to differentiate.
Yeah, what are the points?
Inflammatory, there is T2 hyper. Inflammatory changes will appear as hyper.
See, in this case, you directly described this as a mass lesion. You didn't even think of a mucosal disease. Why?
Because of the expansion and
expansion, even a sinonasal polyposis can also cause expansion, but not this much of expansion, but expansion will be there. What is the point that made you think that this is a mass lesion and not an inflammatory mucosal disease? You started directly describing this as a lesion, right? See, fungal sinusitis can be very aggressive. See, basically, you're seeing an enhancing mass lesion. So that is the basic point that differentiates an inflammatory mucosal disease from a mass lesion. Inflammatory lesions, you only see the mucosa enhancing, not the inside the polyp. The mucosa will not enhance, only the mucosal lining will enhance. But here you see the whole chunk is enhancing. So that is the basic point that you differentiate a tumor from a, if you see an enhancing soft tissue density within a in sinus and nasal cavity, you should always think of a mass lesion. That is the basic differentiating point. And you said MR. Actually, MR is more important in differentiating these two. How? What is the main in MRA? How will you differentiate an inflammatory mucosal disease from a tumor?
In MRI, the inflammatory disease will be appearing hyperintense in
Yeah,
T2.
so this is basically fluid. So it will be very bright on T2, while tumor,
It will be hypercellular tumors will be more hypoattenuated.
so T2 it will be hypo. So it will be hypointense to the mucosa or hypointense to the fluid. So that is how we differentiate an inflammatory mucosal disease from a mass lesion. So that is the first role in imaging. So you should always differentiate from a mucosal disease and a tumor. Once we know that this is a tumor, then what is our role? Finding the epicenter of the lesion. Epicenter, extension, and further invasions and infiltrations. Okay, so now in this case, you have actually come to a conclusion that this is a tumor. And now, where do you think the epicenter is?
Nasal cavity, because most of the lesion is seen within the nasal cavity.
Yeah, it's basically, and you are seeing a focal hyperostosis. That you correctly said that it is most commonly seen in inverted papilloma. And in inverted papilloma, this focal hyperostosis is always seen at the site of attachment, where it is origin. So that origin is always indicated by this focal hyperostosis. So where does an inverted papilloma usually originates?
Lateral wall of nasal cavity.
Yeah, so you see, this is seen in the, yeah, so you're seeing this focal hyperostosis centered in the lateral nasal wall. So this is one point that tells you that the point that favors inverted papilloma is a focal hyperostosis that is centered in the lateral nasal wall. You agree that, right?
Yes, ma'am.
And where is the most common site of squamous cell carcinoma in paranasal sinuses?
Maxillary sinus.
Yeah, maxillary sinus. So it's basically a squamous cell carcinoma. Usually it will be, the epicenter will be in the maxillary sinus, not here. So that is again not a very specific point, but again to differentiate between an inverted papilloma and a squamous cell carcinoma of the maxillary sinus. Okay, see now, you have found out the epicenter of the lesion, and now the extensions. You didn't actually tell when we were describing the case, you actually didn't go in detail to the extensions. So what all extensions you should actually tell in this case?
In this case, intracranial extensions.
Yeah, so before going to intracranial, the local extensions, it is actually seen reaching up to the anterior nasal, the anterior nair. It is extending up to the anterior nair, and posteriorly it is extending up to the choana. And you are not seeing the middle terminate. Middle terminate, all this ethmoid cells is not seen. It's completely involved by the lesion, and it's this you told is extending. It's almost filling the maxillary sinus, sparing this much part. The inferior, the most posterior inferior aspect is spared. You are not seeing enhancement there. That is, so this is mucosal disease. This is tumor. See the difference in enhancement. Yeah. And the important thing in any sinonasal tumor is two things. One is extension into the two important things that you should always tell, either positive or negative. In paranasal sinus tumors are extensions into, what are the two important adjacent structures that you should, orbit. And second is, you already told, intracranial extension. See, definitely there is no intracranial extension here, but it is reaching up to this cribriform plate. This part is actually nascent, but you see there is no extension into the intracranial. Which modality is more important in this? MRI. So MRI, what are the advantages in this intracranial extensions? How do you know? There are actually 3 points which is very important that we always see in MR. What are the 3 things in paranasal sinus tumors regarding the intracranial extension and the base of skull extension? How does MRI helps? See, base of skull extension, what is the thing that you see in MR? Early base of skull invasion can be picked up in MR. How? Even before that is seen in CT. What is the normal signal intensity of the marrow of the base of skull? It will be T1 hyperintense because it will be fatty marrow. So if you do that fatty marrow, the T1 hyperintense signal is lost. When it becomes T1 hypointense, That is an early sign of base of skull invasion. Okay. The second thing is perineural invasion, because certain tumors can cause perineural invasion. So perineural invasion again can be most clearly seen in MR. And definitely early intracranial extensions, like gross intracranial extension can be seen in CT, but very early, like dural enhancement, very nodular lesions within the extra-axial areas. So that also again will be more clearly seen in MR than in CT. So 3 points: early base of skull invasion by looking at the marrow signal intensity, 2 perineural invasion, and 3 is early intracranial extensions. Okay, so these 3 can be actually better delineated by MR than in CT. Okay, so here in this case, there is no intracranial extension. You said that correctly, but you said there is no orbital extension. Now, let me actually see this area. What is happening?
Bone dehiscence is there. And there is
Yeah.
mild extension to the medial wall.
Yeah, that's right. So here you can see that this part, there is actually destruction of what is the bone here? What is this bone? Lamina papyrus. So there is destruction of the lamina papyrus and there is extension into the extracorneal compartment of the orbit, but there is no infiltration of the, what is this? It is this muscle?
I cannot see the pointer.
This one. You're seeing the pointer, right? Okay. Oh, which is that medialmost muscle?
Medial rectus.
Medial rectus. So there is no infiltration of the medial rectus, but definitely there is extension to the extra, and there is actually some bone destruction here. Usually you don't see a bone destruction in inverted papilloma. If you see a area of bone destruction, what is that you always think?
Malignant transformation.
Malignant transformation. Whether it is common in inverted papilloma?
About 12, less than 4, about 30%.
Yeah, it is common actually in inverted papilloma. It is common. So what are the points that favors malignant transformation in inverted papilloma?
Bone destruction.
One, bone destruction. Second, necrosis. If you see here, this part, if you see carefully, this part you're seeing actually a focus of necrosis. You're seeing a non-enhancing area with the air pocket in the medial aspect of the orbit, and you're seeing a destruction here. So despite like all other features are suggesting the possibility of inverted papilloma, this focal destruction, you should always give in your report that there is a chance of malignant transformation. And what is the typical MR appearance in MR appearance of inverted papilloma?
Cerebriform appearance.
Convoluted cerebriform appearance. What is that appearance? How does it happen? It can be seen in both. It can be seen with which all sequences?
T2 and stir and post contrast T1.
And post contrast. You see alternating hyper and hypointense bands. So if that convoluted cerebriform appearance is lost, that also favors a malignant transformation. So 3 points. 1 is loss of convoluted cerebriform appearance, 2 is necrosis, and 3rd is bone destruction. So if you see this, you should think the possibility of a malignant transformation in inverted papilloma. Any other DD in this case?
Neuroblastoma.
Olfactory neuroblastoma. Again, what is the age group and what is the appearance?
It usually involves the superior aspect of the nasal cavity with common extension into the intracranial aspect. Yes, it is actually, so the epicenter is very important in all cases. So there are certain points which gives you the clue that this is this. So if a lesion is epicentered in the olfactory cleft, younger patients with intracranial extension, you should think the possibility of a olfactory neuroblastoma. And if you see perineural cyst,
surrounding the in the intracranial component again favors olfactory neuroblastoma. Do you know any other sinonasal tumor centered in the olfactory cleft? One is olfactory neuroblastoma, one benign condition. It is actually described in the recent WHO classification of sinonasal tumors. It's called REAH, R-E-A-H, respiratory epithelial adenomatous hamartoma. So that is again a very benign lesion that is centered in the anterior olfactory cleft without bone destruction. There is just expansion of the olfactory cleft. The site is very typical. It can be kept as a spot also. It's actually described recently. It's called respiratory epithelial adenomatous hamartoma. Okay, it's called REAH. Any other tumors that you know, benign tumors of sinonasal origin? Any other? I'm just asking. So this final histopathology came as inverted papilloma with focal malignant transformation. So that part we saw actually was a malignant transformation. The main histopathology was inverted papilloma. Okay, so this in this case, this typical hyperostosis and centered here is a clue that it is an inverted papilloma. This can be actually kept as a short case. This is the typical site of inverted papilloma, and all these points you need to discuss. Okay, so any other tendinous tumors you know?
DD, ma'am?
Not DD. DD in this case, it can be inverted papilloma or sinonasal carcinoma. So these two can be actually can be kept as a DD. You said olfactory, so you can tell all the other benign tumors and to tell that it's not typical of this. See, all other sinus, you can have all those leiomyomas, schwannomas, that salivary gland tumors. Everything can occur in the sinus tumor, but the imaging features are rather not specific. But you can tell that these are the benign lesions and it's not specific. So there are certain clues. Even I told you the role of imaging in sinus tumors is one is differentiating from the inflammatory disease, two is localization and extension. That actually helps the surgeon to resect the tumor. And if it is not resectable, if it's highly infiltrated lesion, you should always guide them like from where to take the biopsy. So these are actually the role of imaging, and most of the times it's actually very difficult to come to a histopathological diagnosis in CT or MR. But there are certain clues. Example, this inverted papilloma, this REAH, olfactory neuroblastoma, or a sinonasal carcinoma. So these have a certain typical features that actually helps. So we need to pick up that findings and come to a diagnosis. Okay. Yeah.
Okay.
So, okay, Rosmi, I think you have done it. We'll go to the next case. Maria, right?
Yes, ma'am.
Ready?
Yes, ma'am.
Okay. So this is a 55-year-old male who presented with a neck swelling. You're seeing the image, right?
Yes, ma'am.
Okay. So 55-year-old male patient. Okay. Okay. You can start describing.
In the
So basically, I'll just help you. So basically, you are seeing a neck mass, right? So what is the approach in any neck mass?
first is to identify from the space from which the mass is arising,
Very
and
good.
to based on
So
the
can you
contents
just,
of
for all the residents, can you just tell me what all neck spaces that you know?
yes, ma'am, pharyngeal mucosal space, which is the midline, and
Yes, this one.
yes, ma'am, and on either side we have the parapharyngeal space
and
Very good.
androlateral to the parapharyngeal space, we have the masticator space,
This
and
one. Yes.
posterolaterally the parotid space,
Yeah,
and
this one.
posteriorly the carotid space or the
Very good.
pre-styloid parapharyngeal space.
Parapharyngeal space. You have a
Post-styloid
Yeah.
parapharyngeal space.
Very good.
And another space is the retropharyngeal space. And anterior to the vertebra is the prevertebral space.
Yeah. This the whole thing is a perivertebral space. And where you see the fat is the retropharyngeal space and the danger space. Both comes there. It is difficult to differentiate the retropharyngeal and the danger space in routine cross-sectional imaging. So this fat is the retropharyngeal fat you see here. Pharyngeal mucosa. So you have basically a median space and the lateral spaces. So median spaces, you have the pharyngeal mucosal space, retropharyngeal danger space, and the perivertebral space. And the lateral, basically the parapharyngeal spaces and the other lateral spaces. So basically parapharyngeal, pre-styloid parapharyngeal, post-styloid carotid space. And you have all those masticatory, parotid, submandibular, sublingual spaces here. Okay. And basically before that, how do you differentiate the next spaces basically into suprahyoid and infrahyoid? Why such a difference?
Different facial layers, the superficial and deep cervical facial layers separates the neck spaces.
Is there any difference in the neck spaces in the suprahyoid and the infrahyoid compartment? Or rather, which space actually extends both in the suprahyoid and infrahyoid, but there are certain spaces which is there only in the suprahyoid.
Yes, ma'am. The parapharyngeal space extends up to the greater cone of hyoid, and the pharyngeal mucosal space also extends up to from skull base to the up to the.
So we call this a pharyngeal mucosal space in the suprahyoid compartment, and we call it the visceral space in the infrahyoid compartment. So parapharyngeal space basically extends only up to the hyoid. And the carotid space, perivertebral space, everything extends from both suprahyoid and infrahyoid. Okay, so you know about the neck spaces. So all the residents should know the neck spaces, its normal contents, and the most important lesions that originate from each space, because this can be actually kept as a short case for you in your exam. So now, so first you have to localize a lesion in which space, and to think about the normal contents, and then think about the commonest lesions that come there. That should be the approach in any neck mass. So in this case, what do you think this lesion is?
There is a non-homogeneous, almost well-defined, mildly lobulated margins of a ovoid lesion that is seen occupying the left parapharyngeal space, and and there is mild shift towards the right side. The parapharyngeal. There is mild midline shift of the oropharynx towards the right side. Ma'am, can I get the T1 sequence?
This is the T1FS, and this is the coronal T1.
Yes, ma'am. On the right side, we can see that the parapharyngeal fat as T1 hyperintense area. On the left side, it appears be pushed towards the right side.
Okay, so this is the parapharyngeal fat you see normally on the right side, and this is the, you're seeing my arrow, right?
Yes, ma'am.
So this is the parapharyngeal fat that is actually displaced medially by the lesion. But you said that this is in the parapharyngeal mass. But why you are telling it's in the parapharyngeal, not in the carotid space?
The carotid space, because ma'am, the carotid vessel was seen, the carotid space, carotid structures were seen posteriorly displaced, mildly posteriorly displaced.
So what is the normal content of the carotid space?
In the carotid space, we have the common carotid artery, internal jugular vein, vagus nerve anteriorly, and the posteriorly.
Vagus nerve anteriorly.
Sorry, ma'am. Vagus nerve posteriorly, and the sympathetic chain medially.
Very good. Is there any
and-
difference in contents in the suprahead and infrahead compartment of the carotid space?
Yes, ma'am. Internal carotid artery. The internal carotid artery, and then internal carotid artery after bifurcation also forms the part of carotid space in the suprahead compartment.
Yeah,
and
yeah, that is there. See, carotid and the branches are there in the carotid space. Any other
and the
difference?
nerves, ma'am, the nerve structures from 9, 10, 11, and 12 forms the contents of carotid
Yeah,
space.
very. So yes, that's what. So in the suprahead, you see all those other cranial nerves, but in the infrahead compartment, you have only the 10th cranial nerve within the carotid space, because all other cranial nerves exit from the suprahead carotid space. Okay, so you're seeing all those carotid space contents posterior to the lesion. So that is not in the carotid space. So it should be in the parapharyngeal space.
Parapharyngeal space.
So what is the, do you know the anatomy of the parapharyngeal space?
Yes, ma'am.
What is the shape?
It is a inverted pyramid shaped structure.
Very good. Yes.
With apex point towards the greater corner of hyoid.
So this is the inverted pyramid shape thing.
Yes, ma'am.
And what are the normal contents?
Normal contents is the parapharyngeal fat, ectopic or minor salivary gland rests.
Very good.
There can be vessels ascending pharyngeal artery, internal maxillary artery, pharyngeal plexus, venous plexus, and also the mandibular branch of trigeminal nerve.
Okay, very good. And what are the usually the most common structure or the lesions that are seen in the parapharyngeal space?
The primary tumor arising from the parapharyngeal space is the benign mixed tumor that arises from the salivary or ectopic salivary gland rests, and also parapharyngeal neurogenic tumor that arises from the mandibular branch of trigeminal nerve, and also lymphoma that is arise from the parapharyngeal fat. Also the lymph node enlargement is also possible.
Very good. So it can be basically an intrinsic lesion, it is originating from the parapharyngeal space, or an extrinsic lesion which comes from the surrounding neck spaces. So how do you differentiate these two?
The primary tumor that is arising from the parapharyngeal space, there will be maintained fat plane. That parapharyngeal fat will be maintained around the lesion, and there won't be any. There will be uniform displacement of the surrounding spaces than a symmetrical displacement. And in the secondary tumors that is arising from surrounding spaces will cause the shift of the parapharyngeal fat space towards a particular side, and also there will be displacement of the structures based on the space from which it originates.
Very good. So which is the most common extrinsic lesion that we see in the parapharyngeal space?
Can be the lesions arising from the deep lobe of parotid, ma'am.
Very good.
And also the carotid sheath structures, the lesions from the carotid sheath structures can also cause lesions that protrudes into the parapharyngeal space.
Okay. Yes, very good. So you know all those theory. Now come to the case.
Yes, ma'am.
So what do you think this is? Is this an intrinsic lesion of the parapharyngeal space or an extrinsic lesion coming from any of the surrounding neck space? What are the clue?
The one clue is that, ma'am, the parapharyngeal fat and the oropharynx is mildly shifted to the right side, and the lesion is an ovoid lesion that seems pushing the parapharyngeal fat medially.
Yeah.
And there is no evidence of such a fat plane around the lesion, excluding that it is a primary tumor from the parapharyngeal space. So next is to identify the surrounding spaces from which it originates. Comparing the both sides, ma'am, on the right side we can see the deep lobe of parotid separately, but on the left side that deep lobe is not distinctly visualized, and also there is no fat plane that separates the parotid from the lesion, as well as the lesion is causing mild posterior displacement of the carotid sheath structures. And anteriorly, the masticatum, pterygoid muscles, the medial and lateral pterygoid appears compressed compared to right side, where it is both are distinguishedly visualized. On the left side, it appears compressed. And also comparing the stylomandibular space, the tunnel, on compared to left side, it appears mildly widened on left side, or compared to right side, it appears mildly widened on left side. That's a space between the styloid and the ramus of the mandible.
Very good. So these are the points actually I expect from you. So you actually told all the important points that help to differentiate from an intrinsic and extrinsic lesion. So now what do you think this is?
So all the imaging findings are in favor of a deep lobe parotid tumor.
Yeah. What is one more point actually I want you to pick in this, which again helps you to tell that this is arising from the deep lobe of parotid. All other points you told. So this is the deep.
There is an enhancing. Compressed.
This is edema, and this is T2FS, and this is T2. You see a difference? Some yes. Edema which is going extending into the deep lobe of parotid.
Yes, ma'am.
And you can also see that in the post contrast also. See, you see that enhancement extending into the deep lobe of parotid. So all the points that you told, that you are not seeing the fat plane laterally, you are only seeing the fat medially. It is displacing the midline structures to the other side. It is sort of infiltrating the pterygoid muscles, and you are seeing this edema and enhancement extending the deep lobe of parotid gland with widening of the stylomandibular foramen. So all these suggest that this is a lesion arising from the deep lobe of parotid gland. Excellent. So now, how do you approach? Next thing. Now we have actually localized this into the deep lobe of parotid gland. Now what is the next step?
Now the lesion morphology, it is almost well defined with mildly lobulated margins, and it was T1 hypointense and T2 intermediate signal intensity. And in the post-contrast images, there is heterogeneous enhancement.
This is a pre-contrast and this is a post-contrast.
Post-contrast, we can see there is non-enhancing hypointense areas within. And also there was a hypointense rim surrounding the lesion, which could be the capsule that was seen in the previous sequence. Hypointense.
This one?
Yes.
Are you telling about this?
Yes.
Yeah, it's actually seen within the lesion, actually not the capsule.
Oh.
I think I have the No, I don't have the actually that is showing GRE blooming, and the correlative CT was showing a curvilinear calcification. So that hypointense thing was calcification. Okay, so see, basically, what are the type of tumors that you think rising from the deep lobe of parotid gland?
Most common is the pleomorphic adenoma, and it's a benign lesion with well-defined margins. And
okay, so basically, you need to identify whether this is a benign lesion arising from the parotid or a malignant lesion arising from the deep lobe of parotid. So what are the imaging features that help you to differentiate both?
In malignant lesions, it will be of irregular margins, and also it will be aggressive lesion with a perineural invasion, involvement of the facial nerve, And also there will be extra parotid infiltration, and also the important prominent significant cervical lymph nodes also will be there.
Okay. Yeah. So, coming first to the morphology of the lesion. Morphology, it's not very irregular. It appears to be lobulated round lesion. So that actually doesn't help. Coming to the signal intensity, what is the difference of benign and malignant?
T2.
T2 and post contrast. What are the features that help to differentiate between a benign and a malignant parotid tumor?
In malignant lesions, the in T2 sequence, it will be hypo-intense.
T2, it will be hypo-intense.
Yes,
benign tumors, especially pleomorphic adenoma, will be very bright on T2. We sometimes can mistake it for a cyst. So it will be very bright on T2, pleomorphic adenomas. Why? Malignant tumors will be T2 hypo-intense because of the high cellularity. So is this what you think? Is this very bright or T2 hypo?
T2 intermediate.
Yeah, it is not very bright on. See the mucosal normal bright, very mucosal. So when you compare with that, and it is actually intermediate or more hypo-intense rather than the very bright high signal intensity that we see in pleomorphic adenoma. And post contrast, what is the difference?
It's a heterogeneously enhancing, ma'am. There are non-enhancing hypo-intense areas suggesting.
Definitely, you see non-enhancing necrotic areas within. So that again, so out of which, so what do you think this most likely, malignant or benign?
The heterogeneous enhancement and the T2 hypo to intermediate signal intensity is in favor of a malignant.
Malignant, yeah. So malignant etiology, what are the malignant tumors that you know arising from the deep lobe of parotid?
Adenoid cystic carcinoma and mucoepidermoid, mucoepidermoid
correct
carcinoma, and those are the malignant lesions.
Yeah. So if you identify this as a malignant lesion, what is the specific finding that you should always look for?
The facial nerve involvement.
Not facial nerve. Perineural infiltration, because that is very common in salivary gland malignant tumors. So in this parapharyngeal space, which perineural infiltration is more common and what should we look for?
In parapharyngeal space, the mandibular branch of trigeminal nerve involvement to be looked for.
Yeah. So where you have to look? Through which foramen mandibular nerve comes?
Mandibular foramen from foramen ovale.
Foramen ovale. Yeah. Did you see the foramen ovale in this case? See, it is causing some infiltration of the lateral pterygoid muscle. We are seeing some enhancement extending into the lateral pterygoid. And what is this foramen here? And this is the normal foramen ovale here. You see this?
Yes, ma'am.
What is happening? Did you see the normal foramen ovale here? This is the normal foramen ovale. What is happening here?
There is widening and enhancing. There is widening and
this tumor is actually extending into the foramen ovale. So what does it indicate?
Perineural invasion into the mandibular
along the mandibular branch of the trigeminal nerve. So it is not extending up to the Meckel's cave. You're seeing the Meckel's cave normally here. The Meckel's cave is normal here, but it is extending into the mandibular branch here. This is actually widened. So what is your final conclusion? So these are all the findings, and actually you told all the findings. And now how you summarize?
So in a 60-year-old patient with a heterogeneously enhancing lesion with lobulated margins, which appears hypo to intermediate signal intensity in T2 sequence, that is seen causing mass effect, like pushing the parapharyngeal space fat medially, anteriorly causing compression into the masticator space, posteriorly displacing the carotid sheath structures, and also showing extension into the foramen ovale, causing mandibular nerve invasion, and there is widening of the stylomandibular tunnel, and also there is loss of fat plane between the parotid and the lesion. All these findings are in favor of a malignant lesion that is arising from the deep lobe of parotid gland.
With perineural invasion. Okay, so this is how we should present this case. Hope you understood the way which you need to present the neck mass. So this should be the approach in any case. So I just took a parapharyngeal mass, but that should be approach in any neck mass lesions. Okay, because this can be actually kept as a short case. Okay, you did it well. Very good.
Thank you.
Okay, Maria. Okay, Vijay, right?
Yes, ma'am.
You're seeing my screen, right?
Yes, ma'am, I can see it.
Okay, this is a 73-year-old male patient with dysphagia and some neck swelling.
Okay.
See, basic now, actually, we are coming into the pharyngeal mucosal space.
Yes, ma'am.
So the previous case, we have actually seen a lateral space lesion. Now we are coming to the medial aspect. So pharyngeal mucosal space lesion, basically. Okay. Again, as in any other case, the epicenter is very important. So you should first localize the lesion to one particular space. So how do you classify the pharyngeal mucosal space? What are the different type of pharyngeal mucosal space? You have basically starting from the base of skull.
Base of skull to the includes the oropharynx.
You start from the base of skull.
Base of skull.
What is this area?
This is the nasopharynx.
Yeah, nasopharynx. So nasopharynx is from the base of skull up to?
Basis. Up to the level of the junction of hard palate to soft palate.
Hard palate, yes. So this is the nasopharynx, and second part of the pharynx?
Oropharynx.
Oropharynx. That is from which level to which level?
Is from the level of the hard palate to the level of the hyoid.
From the level of the hyoid, yeah. And below the hyoid up to cricoid is the
lower part of cricoid is the hypopharynx.
Is the hypopharynx. And you know the three parts of the hypopharynx? What are the three parts of hypopharynx?
So, supraglottic.
No, that is the part of larynx. Supraglottis, glottis, and subglottis. I'm asking about the hypopharynx. Three parts. One is the posterior pharyngeal wall. Second is the pyriform sinus. Third is the post-cricoid. Yeah. Okay. So, so what is the abnormality that you're seeing here? Are you finding a lot of lesions here?
Yes, ma'am. It's this.
Where is the epicenter? So you can actually pyriform sinus. Do you know the exact anatomy of the pyriform sinus?
Yes, ma'am.
How do you identify?
So research which is bounded medially by the iliopygoid fold and laterally by the thyroid cartilage.
Very good. And where is the apex of the pyriform sinus?
It's inferiorly.
It's at the level of the cricoarytenoid joint. Cricoarytenoid joint. Any other landmark? at the level of the cricoretinoid joint? That is the level of, what is the level of cricoretinoid joint? The level of the true glottis.
Okay.
Do you know in MR, how do you differentiate a true glottis from the supraglottis?
True glottis is at the level of the arytenoid and cricoid cartilage. Junction of arytenoid and cricoid cartilage.
It's basically at the junction, you see the true glottis at the level of the cricoretinoid joint itself. Another point is that in the supraglottis, you always see the paraglottic fat here. So when you stop seeing the paraglottic fat and when you see this thyroarytenoid membrane, muscle, not membrane, muscle. So you see the muscle signal intensity rather than the fat signal intensity. That is the level of the true glottis. So two ways by which you identify that is true glottis. One is the level of the cricoretinoid joint, and second is you see the muscle instead of the paraglottic fat. Okay. So like I am deviating from the main topic. So basically you see a lesion in the pyriform sinus. See, there is a doubt that whether this is arising from the supraglottis or the pyriform sinus, or you are confident that is arising from the pyriform sinus?
Ma'am, predominantly the majority of the lesion looks like to be in the pyriform sinus.
Okay. How do you differentiate a pyriform sinus lesion from a supraglottic lesion? Because it is actually in the supraglottic level. You see a lesion in the supraglottic level.
But it's extending laterally to the apex of the pyriform sinus.
Yeah. So there are certain points which actually helps you to differentiate a supraglottic tumor from a pyriform sinus mass. So usually the supraglottic tumors, it grows circumferentially and it will be bilateral. It can actually extend into the pre-epiglottic space and extend bilaterally, while pyriform sinus lesions will be unilateral. And it can invade the thyroid cartilage, and extralaryngeal spread is more common in pyriform sinus. Yes. So now you come to you have seen this case, right? So what do you think? What is the extension of this lesion? Now, can you describe the lesion? I've just helped you to localize this in the pyriform sinus. Can now just describe the lesion?
T2 hypotenuse lesion, which is predominantly involving the pyriform sinus, and it's also extending along the.
See, in your exam, the side is very important. You just now mentioned that is in the pyriform sinus.
It's the left side of the left pyriform sinus.
That is very important. Yeah.
And it's extending. It's also we can see the similar lesions in the left side of the pharyngeal mucosal space in the oral in the region of the oropharynx, as well as on the right side also similar lesion can be seen in the region of the oropharynx.
What is this?
It's the tonsils.
Yeah, that is a normal tonsil that you see.
Tonsil, okay.
See, so this is a normal tonsil.
Okay.
But definitely, when you see the axial, there is some asymmetry here, and you see this actually a soft tissue lesion here in the region of the left tonsil. Okay. Yeah. See, when you are describing, always go in a systematic manner. See, now you said that there is a tumor there is a mass lesion in the pyriform sinus. And what is the usual way of extension or the usual spread of any lesion? Because this is an elderly, this is a 73-year-old male patient. So first thing that you should always think is definitely it is a malignancy arising from the pyriform sinus. Correct. So if you think that it's a pyriform sinus, the extension is more important. So first, rather than jumping into the oropharynx, first you describe the extensions in the pyriform sinus. So for that, you have to know the normal extensions of a pyriform sinus. How does a pyriform sinus CA extends? Or what is the usual way of spread? There is some, this pyriform sinus tumors or a hypopharyngeal cancers have a specific nature, which is not seen in other pharyngeal tumors. What is that?
It can show submucosal spread.
Very good. This is the tumor which always shows submucosal spread. What is the importance of submucosal spread?
It can extend along the lymphatics.
Yeah. So the importance is that usually, like, how will you diagnose a pharyngeal tumors? By endoscopy. The clinician can directly visualize the lesion in the endoscopy. But these tumors with submucosal spread, they actually don't see the lesion in the mucosal space. So endoscopy, the majority part of the lesion will not be visualized in endoscopy. So only by a cross-sectional imaging, we can actually see the entire extent of a hypopharyngeal lesion. So that is the importance of this submucosal spread. The clinicians will not be able to see it in endoscopy. We have to tell them that this is actually extending this and this. And what are the usual submucosal spread patterns of a hypopharyngeal tumor? If you don't know, you can tell me, like, I'll help you. No issues. See, medially, where does it spread? It's very easy. Just know the anatomy. See, medially it extends into the larynx, the supraglottis, the epiglottic fold. The most common spread is, see here also, if you can see that it's extending in the supraglottic space. That's why I asked you whether this is supraglottic CA or a piriform sinus CA.
Yes.
Because it always spreads into the, what is this space called? And this space called? This is the paraglottic space and this is the pre-epiglottic space. So it spreads into the paraepiglottic space. That is the first spread into the submucosal medially. And posteriorly, where does it spread?
Hypopharynx.
This is basically hypopharynx. It can extend into the post-cricoid area. Again, that is a submucosal spread. So this is the post-cricoid pharynx. See, are you seeing? This is the post-cricoid pharynx. So it can spread into the post-cricoid pharyngeal pharynx also. And then, so that is about posteriorly and medially. Then laterally, where does it spread?
To the cartilage, no? Thyroid cartilage.
See, this is the normal thyroid cartilage that you see here. See, so this is the normal thyroid cartilage. What is happening here? It is actually extending superior to the thyroid cartilage and extending into the extrathyroid or extralaryngeal spread is there. So this is the thyroid cartilage and this is actually spreading superior to this. So this piriform sinus CAs have always a tendency to spread either superior or posterior to the thyroid. Because thyroid cartilage is open posteriorly. You know that, right?
Yes, ma'am.
So it can easily spread superior and posterior to the thyroid into the extralaryngeal area. So yeah, so the extralaryngeal spread is very common in piriform sinus CA, not in supraglottic CA. So in this case, you are actually seeing a infiltration of the thyroid cartilage and definitely you can see some irregularity here. That is, it is spreading into the extralaryngeal area. And from there, what is the usual, where does it infiltrate? Where can it go and infiltrate in the, if it has an extralaryngeal spread? See this space, that's a carotid space because it has reached up to here. Large tumors can go and infiltrate and encase the carotid artery and internal jugular vein. So these are the negative points you should tell. So in this case, it is actually infiltrating the thyroid cartilage. Extralaryngeal spread is there, but it is not infiltrating. It is not directly going and infiltrating the carotid vessels. Posteriorly, it can infiltrate the perivertebral, the prevertebral, the muscles. But here in this case, the prevertebral muscles is spared. Okay, and superiorly, it can again by submucosal spread, it can actually reach up to the tonsil and the base of tongue. So that is what it is seen here. So from here, from this, it can directly see it is having the submucosal spread into the tonsillar, reaching up to the base of tongue. Okay, so this is the normal spread. And then what other structure you can infiltrate? When once it is outside the thyroid cartilage, what you have here is the thyroid gland. So that is another spread. So it can, once it has an extralaryngeal spread, you can see the hyperintensity reaching up to the thyroid gland. Understood? So basically, so you have a piriform sinus mass lesion with submucosal spread superiorly up to the base of tongue and the tonsil, inferiorly up to the thyroid cartilage, and medially involving the supraglottis, and laterally infiltrating the thyroid cartilage and into the extralaryngeal spread. Understood?
Yes.
Clear?
Yes.
Any doubt regarding the extension? Because once the neck is all about anatomy. If you know the anatomy, this almost done. So if you know the anatomy, just see like where does all it extends. Okay, so I'm showing a CA hypopharynx because this is one CA that is actually slightly different from a nasopharyngeal tumor or a tonsillar or oropharyngeal tumor because of this typical spread, submucosal spread of the lesion. So to conclude, can you then what are the things that you always see in any CA pharynx, even if it's oropharynx or nasopharynx or hypopharynx? What is the other important point that you should see? Nodal involvement. Okay, so what are the? How do you know that a node is there or not, or what are the radiological criteria of cervical nodal metastasis?
The morphology of the lymph nodes.
One is the most important is size criteria. What is the size criteria?
More than 10 mm in shortest diameter.
That is for all the cervical lymph node. Jugular digastric, it's more than 11 mm. Retropharyngeal is more than 5 mm. Okay, one is the size criteria. Borderline tumor, borderline nodes, that is more than 8 mm. If you see 3 clustered nodes, you can again take that as a feature of metastasis. Then what is the other criteria? Morphology. What is the typical feature in metastatic cervical lymph node?
The morphology of rounded lymph nodes.
One is round. Then
And,
heterogeneous enhancement, or if you see necrosis. So in this case, are you seeing any metastatic lymph node?
one level 3 lymph node is there on the left side.
Okay, what are the cervical lymph nodal levels, you know?
Level 1A, 1B, level 2, 3, 4.
I expect you to tell where exactly these levels are.
Between the in the submental region is level 1A, and in the submandibular space is the level 1B. And
submental is level 1A and this is level 1B.
Level 1B. And from the level of up to level of the hyoid cartilage, hyoid is the level 2. Some skull base to the hyoid is level 2, and from hyoid to the level of cricoid is the level 3, and from inferior to the cricoid is the level 4. And in the posterior triangle is the level 5.
And what is level 6?
Level 6 is the pretracheal,
pre-laryngeal, pretracheal, and paratracheal lymph node. That is medial to the carotids are the level 6, and lateral to the carotids are the 2, 3, and 4. And posterior to the posterior margin of sternocleidomastoid is the level 5. So which level lymph nodes are you seeing here?
Okay.
This.
See that? Can I see the axial section?
Yeah, I'm scrolling the axial.
I can see the coronal only. I cannot see the axial.
You're not seeing the axial?
Yes, ma'am. I am only seeing the coronal sections only.
No?
Yes, ma'am. I can see that. Yes, ma'am. It's posterior to the sternocleidomastoid.
Yeah, so this is actually below the level of, this is the hyoid bone. So below the level of the hyoid bone and anterior to the posterior margin of the sternocleidomastoid. So this is level 3. And do you think this is a metastatic lymph node or a normal reactive lymph node?
It looks like a metastatic lymphoma.
So what are the
Because
features that tell you that this is a metastatic lymph node?
only size, ma'am, it's enlarged in size.
Yeah, definitely it is enlarged.
And the shape of the lymph node.
Yeah, it
And
is
also,
round.
it appears heterogeneous with
Yes.
some irregular margins.
Yes. And what is extranodal extension? That is again one criteria that you always see in CT or MR. Again, that tells us that it's one of the radiological criteria of metastasis. What is extranodal extension?
Irregular margins, which says to perinodal infiltration.
If you see irregular margin, if you see surrounding infiltration. So in this case, actually, the internal jugular vein is not seen. So this is the carotid artery. So this is the normal internal jugular vein here. So the internal jugular vein is not seen in left side. So that means that it is infiltrating the internal jugular vein and it is highly irregular. Okay. So this is the post contrast. You see it's irregular and it's infiltrating the internal. So definitely there is extranodal extension. So if there is extranodal extension, then what will be the end staging in any cervical lymph node? It directly becomes N3. N3. So in this case, there is a piriform sinus tumor with extralaryngeal spread with thyroid cartilage invasion. So that becomes T4 with level 3 cervical lymph nodes with extranodal extension. So that becomes N3. So this is a T4 N3 carcinoma piriform sinus. What can be the DD for this?
Lymphoma.
Lymphoma. How will you differentiate?
Diffusion restriction, like
homogeneous
enhancement with diffusion restriction.
Yeah, so this is actually showing diffusion restriction. But lymphoma, you see like more lymph nodes. Again, that comes under DD. And here you can see very irregular lesion, it is extending outside extralaryngeal spread. That is again very uncommon in lymphoma. Lymphoma, you see well-defined lesions in the submucosal with the involvement of the tonsils, adenoids, likewise. And this sort of a submucosal spread is uncommon in lymphoma. But definitely you should give a DD of lymphoma also. Okay, what other tumors can come in the other than carcinoma and lymphoma? What other tumors can come in the pharyngeal mucosal space?
Minor salivary gland tumor.
Yeah, all the salivary gland tumors. Okay. Someone actually asked to explain the lesion. You were not seeing the axial, right? Okay, there's some. I thought you were seeing both my axial as well as. Yeah, so axial. See, this is the piriform sinus lesion, which is actually extending anteriorly into the supraglottic or the paraglottic space, and then superiorly it is infiltrating the thyroid and extending outside. So this is the extralaryngeal spread and invasion. So even in the post contrast, you can see that this is the thyroid cartilage, which is actually you're seeing this is the normal signal intensity of thyroid cartilage where it is completely lost. So there is definitely infiltration of thyroid cartilage and extension outside into the extralaryngeal spread and invasions of the strap muscles. And this is the lymph node here. And from here downward, it is reaching up to the apex of the piriform sinus. So what is the importance of the apex of the piriform sinus? If a lesion is involving the apex of the piriform sinus, you need to do a total laryngopharyngectomy. If it's not involving the apex of the piriform sinus, but it's only involving the thyroid cartilage, they can actually go for a partial laryngopharyngectomy. So that is the difference of commenting on the involvement of the apex of the piriform sinus. And then again, superiorly, it is extending into through the submucosal space up to the tonsil. So this is the involvement of the tonsil and some involvement of the base of skull. And the nasopharynx is completely free. So which are the carcinomas can just present as a occult primary? You only see lymph nodes. You don't see pharyngeal mass per se, but here in this case there is a large mass, but sometimes you need to look for an occult primary. So which are the sites that,
Nasopharyngeal lesion.
yeah, you should look the fossa of Rosenmuller, this
Tonsils.
part. Second is, yeah, tonsil. Third is piriform sinus. So piriform sinus lesions can, small piriform sinus lesions, because it's high in lymphatics. So that is one area which can actually cause lymph nodal metastasis and can present as an occult primary. And other is a base of tongue or a tongue lesion. In small lesion can also present as cervical lymph nodal metastasis. Okay, and inferiorly it is actually reaching up to the thyroid, and there is a thyroid mass. So this is an extensive CA piriform sinus extending superiorly and inferiorly. So this is a very it's a typical submucosal spread of a CA piriform sinus. Any other questions? Can you please tell supraglottic and glottic region in axial normal anatomy? Yeah, that's what I had already explained, right? See, supraglottis is basically starts from the aryepiglottic fold. From the aryepiglottic fold, you have the supraglottis. So you have the paraglottic space. So if you see the normal fat here in the paraglottic space, that is the supraglottis. And once you stop seeing the normal fat and start seeing this signal intensity of the muscle, that is the thyroarytenoid muscle, and you see the cricoarytenoid joint. So this is the level of true glottis. And below that, you see when you start seeing the cricoid. So cricoid is the round cartilage, while this is an open cartilage, thyroid. So once you see the cricoid, this is the subglottis. And then when you start seeing the tracheal cartilage, this is the trachea. So that is how in axial you identify the supraglottis, glottis, and the subglottis. Hope that is clear. Any other questions? I think that's all. Any other questions you can actually put in the Q&A section. Vijay, clear?
Yes, ma'am.
I think you are actually very hesitant to present. You know everything, but because you can actually start presenting more cases, and this will actually, you'll be like more free to talk. That's what I felt about you. And Maria and Rosmi, well done, no issues. You also told, but some block is there. That's what I felt. Okay, start presenting more cases, then it'll be okay. Okay, then.
Yeah, thank you.
I think no more questions are there. I think that's all from my side.
Yeah, you have, they have asked many questions. You have answered everything.
Yeah. Can we differentiate true and false chord? Same thing. False chord is supraglottis, true chord is...
Yeah, same thing.
Which book to follow? See, for the head and neck, the gold standard or the Bible is Peterson.
Yeah.
It's very difficult to read. It's a very good book, but certain areas you actually have to read Peterson. And again, for neck, actually, it is anatomy. If you know the anatomy, then it's very, very, very easy. And like MRI of neck is actually a little bit tough. But once you know the anatomy, it becomes very easy. And start reading more journals. In CA hyperpharynx, go and read a journal. For neck masses, go and read a journal. There are a lot of good journals. So, like at my level, I always try to read journals now. But during my residency, I used to read Peterson and of course Haga. That is also very good for head and neck. Okay. That's all, ma'am.
Yeah.
Okay. Shall I conclude?
Yeah, we can continue.
Shall I conclude?
Yeah. Yes.
Okay, Doctor. Dr. Rashmi, actually, today's the 3 cases actually very good, very representative, and I think the last case is little difficult for the postgraduates, especially the anatomy part is little complex now. Regarding the first case, actually, the many times the people usually make a mistake. That is, when they start describing the lesion, first they will tell the it's enhancing mass or something like that, and afterwards immediately they are going to explain the extent of the lesion. Actually, by describing going
I think he lost connection.
Yeah. He's traveling, I think. That's why.
That's it.
He'll join. Actually, it was very good because head and neck is very difficult for most of the residents to report also. And only few examiners bring the laryngeal carcinoma or pharyngeal carcinoma or hypopharyngeal. Only few, very few bring. But thyroid, most of them bring thyroids. Nasopharyngeal carcinoma, usually they get it.
Yeah.
But still, students should know the anatomy before they present. That is very, very important. And the spaces also is very, very important.
Yeah, correct.
Because the surgeons also need that, isn't it?
Correct. See, once you know the anatomy, neck is very easy. That's what I always felt.
Yeah. So I think Dr. Menu has lost his connection. I would like to thank Dr. Reshmi for presenting such wonderful cases for the students. The students should not miss, because once they miss it, they studying by ourselves is very difficult. Once somebody teaches, it will be more easier. That's where we have taken this strain to teach the students. Actually, we are spoon feeding our residents. They should take advantage of it.
Yeah, like during our residency, we didn't get such an opportunity. I will always tell my residents.
We have read by ourselves. Nobody had taught us. All we have read by. So they should take this advantage, and it will be very helpful also even after they pass out for reporting.
Correct.
So I really thank Dr. Reshmi for presenting such wonderful cases, and all the residents also. They have come online, isn't it? That is also, most of the residents are inhibited to come, but they have come and given their talk. So I appreciate them and I congratulate them also. Thank you so much. And I thank Dr. Venu for being with us, our academic chairman, Dr. Ramesh, Dr. Rijo. And last are all the delegates who were listening to the talk, Dr. Soumya, our tech team, who were with us without any interruption. So thank you one and all, and good night to everyone.